Thank you so much for having me. I'm so excited to be in conversation with y'all. Can you see my screen?
Yes, it looks great.
Okay, great. Thank you so much. Well, thank you so much for having me today. I'm really excited that I could share space with y'all and just kind of really, close out the time together. I'm going to be sharing on decolonizing mental health and sharing a bit about my work and just having an Indigenous perspective on looking at things like culture and colonialism. So the plan for our time together, what we'll talk about is we'll do introductions, and then I will talk about, the overall movement of evidence-based practice and what clinical colonization is. We'll look at kind of how culture has been treated or mistreated throughout the DSM. And then I'll introduce the idea of decolonization and what that actually looks like, what it really isn't, and how we can kind of meaningfully introduce that into our clinical practice going forward. So there's this great quote by a Yaqui elder that was shared by Dr. Lydia Jennings, and she said that before you tell me what you know, tell me who you are, right? And I love to start any kind of, talk or presentation with just thinking about, as a way of situating ourselves into the overall conversation that we're about to have. So my name is Autumn Asher BlackDeer. Like I was introduced earlier, I recently finished my doctorate, so still being new to the doctor side of things. I appreciate the invitation to be here. Yay! So I'm actually from the Southern Cheyenne Nation. We are located out in Western Oklahoma. And I like to describe myself as just a decolonial scholar. Everything that I do to navigate the academy and persist in these colonial institutions, whether it be, the overall field of mental health or, higher education, I really could not do it without being grounded in truly decolonial praxis and ways of knowing and being. And so I'm actually located at the University of Denver. I'll be heading there in like a month. So that's where you can keep up with me and my stuff. And I'll also share contact information at the end if there's something that piques your interest and you're interested in learning more about. So getting right into it, talking about evidence-based practice and what clinical colonization is. So evidence-based practice is usually incorrectly referred to, like it became a huge buzzword right as soon as it came out. And so folks started using evidence-based practice to refer to the interventions that people were using that have been supported by research. So that's actually not what evidence-based practice is. That the actual interventions themselves are empirically supported treatments. So those are actually ESTs, not EVPs, right? So whenever evidence-based practice was booming and the whole movement was beginning to come out, the APA came out with 3 categories of these empirically supported treatments. So they said there's well-established treatments, like lots of research, probably some evidence from randomized controlled trials in there, probably efficacious treatments, maybe have some sort of clinical design, but maybe not an experimental evidence. And then experimental treatments, which are, like the lowest tier of evidence, saying that this is probably more, we're unsure of the efficacy, right? So actual evidence-based practice is not the interventions, right? So then like, what the heck is it if we're not talking about the interventions themselves? Evidence-based practice is actually a 6-step process. So it's actually EBPP, evidence-based practice process. And it's really the way that you're supposed to conduct research to inform clinical practice. However, we know that things get co-opted as soon as they become buzzwords and they just kind of take off from there, right? So thinking about, how the overall push for evidence-based practices really began with these government funding agencies who started saying, we want our behavioral health practice to look just like physical health is looking, right? The healthcare system. So the idea was to then move away from having these sort of, individualized perspectives on what works best to then having some sort of like uniform clinical scientific knowledge to then be able to kind of standardize practice, right? So the idea behind it sounds great in theory, right? Like, of course, we would want folks to use things that we know are going to be effective, right? We want to provide the best care that we can for our clients. And then as a person seeking services, right, you want to know that whatever you're, spending your time working on is going to actually be effective, right? But that honestly, it didn't it didn't really happen that way. So just to recap, the perspective of empirically supported treatments versus evidence-based practice are fundamentally different. So empirically supported treatments, they start with the treatment itself, the intervention, and ask, does this work for a specific problem, right? So I would say, like, does cognitive behavioral therapy work well for adolescents with, separation issues? Okay, but evidence-based practice really is supposed to start with the client, with the patient, and then turn to the research or the evidence and say, what evidence will help me as a clinician reach the best outcome in working with this specific client? So it's a fundamentally different perspective, right? The interventions itself just ask, like, does it work for this issue or not, right? The evidence-based practice is supposed to start with the individual through your collaborative, like, in-depth understanding, that therapeutic relationship that you have. Then, knowing all of that, you formulate a research question, you go as a clinician to the research, see what's out there, and then come back, present it to your client. You have a collaborative discussion, presenting different options, and they're able to make an informed decision based off of all of that work that you did. So then you're then combining the patient's interest, your own clinical expertise, and the research evidence to then have this really in-depth conversation about how do you think this would work? What would be the best way to, like, get this into our clinical practice, right? So it's not just kind of like filling the client in, right? Like, oh, I found this study, so this is what we're going to do. It really should be a super collaborative and in-depth kind of interactive process. And so when we get into things, even just talking about evidence-based practice, all of that entire process and, like, looking at the research, collaborating with your client, all of that is missed whenever folks are just saying, oh, it's just the interventions, right? We just need to use interventions that people have done research on and know that they're effective, right? So we're already, if we start with this empirically supported treatment perspective, we're already, limiting our clients' autonomy and, like, self-determination within the clinical relationship. So best case scenario of evidence-based practice being used effectively would be this kind of, circular diagram on the right, where you combine, again, through a thorough assessment, you would know your client's clinical state and circumstances, right? You would have that in-depth understanding, you've been working together for a while. Then you would combine that with their patients, like their preferences and actions, right? So knowing their cultural values, right? Knowing their worldview and their perspective, even knowing how they approach the therapeutic alliance altogether, right? Some folks want to try everything and they're all on board, and we call folks like that, like, maximalists, right? And then some folks are like, less is more. I'm not trying to do homework between sessions. I don't want to do group work, different things like that, which, like, totally fine. And so we have to keep all of these things in mind whenever we're thinking about, we can't just go grab an intervention. And what if it's like the most, the highest held intervention is like 6 group sessions and then an individual, one-on-one. And their client's like, I don't do group work, right? So then what do you do, right? If you're only focusing on the intervention itself and not bringing it back to your client, you're automatically like, that's not going to work, right? So of course we have the relevant research evidence all combined together with you, with a clinician, right? So it's really up to the practitioner to bring all of these pieces together and make it make sense for the client and for your relationship going forward. And so a lot of folks, whenever they talk about evidence-based practice, they just make this, relevant research evidence like the biggest circle, and then everything else is kind of like, the asterisk on the side, like it's in the really small font. And that's not how it's supposed to be, right? They're really supposed to be kind of equal parts that are all brought together. And it really is, ultimately, the process is in the hands of the clinician, right? To weave all of these pieces together. So it's like therapy is an art and a science, right? You have to be able to do both, right? And we have to know how to understand the science and what the researchers are saying, but then also, interpret that and translate that to make it make sense for what we're doing in practice. So overall, we just want to know that this formal evidence or going to the research or looking at things like that to guide our clinical practice, but we want it to still be flexible and inclusive, right? So that we can allow for a range of evidence, which is where I'll kind of be taking us in just a second to kind of talk more about thinking about who decides, what counts as evidence, what is this evidence based off of, who are included in this, these studies that we're upholding as evidence, right? All of these sorts of things that really need to be critiqued and really taken into account. So if we're saying that we understand now that empirically supported treatments are the interventions, right? Evidence-based practice is meant to be the process for how we weave all of these beautiful things together. And so all of that sounds well and good. You're like, Dr. BlackDeer, I don't get it. Like, I did not sign up for a workshop on evidence-based practice. Like, what's the problem, right? Like, if folks follow the 6-step process, I mean, it's pretty, like it's 6 steps, right? You either follow the steps or you don't. So like, what's the issue? Where do we run into trouble? I don't understand how this is even a topic, right? So the issue then becomes, well, there's several issues and we'll unpack all of them. But the major issue when thinking about focusing on mental health equity or liberation, what we're talking about today, is that we have to, kind of step back and have this broader conversation that a lot of these interventions, these empirically supported treatments that we're even talking about, that we find through the evidence-based practice process are built fundamentally on these assumptions of this Western medical model, right? We already know that evidence-based practice, the movement itself, was directly mirrored from the healthcare industry, right? Like government agencies wanted to push behavioral health to look just like healthcare, right? The healthcare industry. So these interventions that folks are now, everyone's coming up with, everyone's getting funding for these things, they're pushing all this information. We have to kind of take a step back and look at the overall worldview or perspective that these interventions are even coming from. And if we look at it, a lot of them look a lot like this Western medical model, right? This overall idea that is emphasizing distress and dysfunction, right? Thinking about things like, what brings you in today? What symptoms are you having? What's the main issue that you want to talk about, right? Inherently deficit focused. And a lot of folks don't have that orientation to life, right? So like, especially in Indigenous communities, we're always thinking about, wellness, right? Holistic well-being, which is a concept that can't really be separated from the community and being in community, that relational perspective, being connected to your culture, right? It's not just kind of like, I can just cut all of that off and then talk about my individual well-being, right? Absolutely. Like what brings you in today? What's wrong with you? And so even the interventions themselves that are designed to help people with certain issues, right? It's inherently based off of that question, right? Like, what is the issue that this intervention needs to fix, right? So we're not even talking about beginning conversations with things like, what goals do you have, right? How can we build on your strengths? Or how can we, what would you like to work on? Like, is it to be more in community? Is, maybe you're feeling disconnected? Is it, relationships with elders, right? Like all of these things to kind of move through that. It's really, we're already starting off on the wrong foot, right? So before we can even get into evidence or the problems with research and these hierarchies and all of these things, we're automatically, not doing well because we're just kind of inheriting this from this Western medical model. And we really have to kind of step back and critique, like, whose perspective is this? Like, whose worldview is being reflected, just even in the assumptions that we're making, the questions that we are prompted to start off with, right? Because it's not really an individual decision at this point, right? It's a systematic structure, right? Where we have intake assessments and we have, we have to go by the DSM and count criteria. And there's all of these, formalized assessment instruments and clinical things that we're supposed to do that are not, we'll talk about culture in a second, but they really do not encapsulate the entirety of someone's personhood, right? Like, yeah, so we'll talk about culture in just a second, and I'll dunk on the DSM in just a second as well. So the idea here, thinking about clinical colonization, right, is that colonization is really, the process of colonialism, right, the lasting impacts of settler colonialism. And so settler colonialism is an ongoing project, right, not just a one-time historical event. And so we have all been impacted by settler colonialism, Black, Indigenous, all of us, like white folks as well, right? And so it's on everybody to unpack and really deal with these impacts of colonialism. So one way that we can kind of see this directly within our clinical practice is that, colonization is like outside folks coming in, imposing their ways of being, and really trying to destroy the initial original inhabitants, right? And so the issue here then is that we don't want to reflect this kind of same practice in clinical work, because it's really kind of incompatible or overall hypocritical to use, interventions or impose these sort of, clinical practices upon Indigenous or communities of color, given that the majority of the distress and dysfunction that we're experiencing began through colonialism, right? So it's kind of like, I really cannot say it any better than this quote, that you cannot be the doctor if you're the disease, right? And so it's really powerful to think about the idea that people not from our communities, right, would come in and tell us that they know what's best for us and then bill us for that clinical service without any kind of relating that to what we're talking about, what we're experiencing, knowing anything really about our communities. So that's fundamentally clinical colonization, really that quote, you can't be both, right? So thinking about the evidence-based practice process imposes these Western ideas upon Native communities and communities of color broadly. So if we're thinking about Indigenous communities as an example, if we're forcing Native populations to select this intervention that's not rooted within any kind of tribal context whatsoever and has no known effectiveness with Indigenous populations, how is that appropriate, right? How can we just kind of continue to do this work and just say, well, it worked with white folks, so it should work for y'all too, right? It's no, there's a lot of things that make us fundamentally different than them that should probably be taken into consideration, especially when, thinking about the clinical relationship, the therapeutic relationship. And so folks have kind of posed the question overall, are Western treatments even appropriate for Native communities? And I would kind of argue that you could probably extrapolate this question to the communities that you serve as well. Because honestly, even European American folks or white folks are still kind of constrained by Western ways of knowing and being. And that's why there's so much of them seeking alternative support. So thinking about are Western treatments appropriate for blank communities, right? And just insert the community that you work with or that you're a part of, right? Because a lot of us don't really ascribe to Western ways of knowing and being and doing, and and that's a whole other talk. I could really dive deep into that sort of thing. But if you want to know more, just thinking about how the idea of like the West as a project, or like the West as informing settler colonialism, you can read Research Through Imperial Eyes by, I think it's Linda, it's either Linda or Eve Tuck. I think it's Linda though. But I'll check up on that and let y'all know. So thinking about other issues with evidence-based practice, as if clinical colonization was not enough of an issue, right? Randomized control trials are the cornerstone of this kind of overall process and research, right? So randomized control trials are this kind of gold standard of evidence, again, directly from this Western medical model of healthcare, right? And so it's supposed to be a super experimental kind of design where you have like your treatment group and your control group, and you're like, you know, you're factoring in all of these other things that could possibly impact what you're looking to study, right? So they have, you know, think about like lab conditions, right? The thermostat is controlled, right? They make sure that there's no other kind of confounding things that could say that, oh, well, maybe this happened because of this, right? They want it to be very clear that A caused B to happen, right? There was no outside influence that let any kind of change happen, right? And so thinking about this with looking at behavioral health is really a bad idea, honestly. So these methods are not compatible really with measuring behavioral health. So if you think about just the one-on-one therapeutic relationship, right? There are really a lot of things that you cannot specifically isolate and control for when thinking about that clinical practice, right? Like you can make sure the thermostat was always set at, you know, 67 or whatever you set it at, that they always sat on the same part of the couch, right? You know, like it's just, it doesn't make sense, right? Like people do not live in vacuums. We're not like lab subjects, right? So there's really not a lot of things that we're working on in clinical practice that can be specifically isolated and enumerated and easily measured, right? And then also the idea of replicability is huge for randomized controlled trials. They want you to be able to kind of show the same things over and over again to be like, yeah, we got the same results again and again. And if you think about it, like I'm always saying, like therapy or, you know, being a clinician is an art and a science, right? And similarly with art, you can't just replicate things, right? Like, so thinking about trying to replicate things like the therapeutic relationship is not really a feasible process, right? Like, how can I say like, oh, I'm just gonna have the exact same mannerisms and conversation and rapport with one person as I do with someone else? Like, that's just not how it works, right? We have our own positionality and perspectives, and you know, the way that we are with our clients or with other folks when we're in community is very different, right? That's not something that we're like, check, they were like this, check, they were like this with someone else too. Like, it just doesn't work that way. So yeah, it's just overall thinking that randomized controlled trials are really just supposed to be the epitome of what research is and what we should be looking to for guidance with clinical practice is really problematic. So given all of this, right, why do we continue to move in the way thinking that evidence-based practice is really the beginning and end for our practice, especially when working with marginalized communities, right? Ooh, for that. So getting into thinking about, you know, we've looked at, you know, in distinguishing the interventions themselves from the actual process. We've started talking about clinical colonization and seeing these kind of fundamental issues in imposing Western ideas of thinking onto working with marginalized communities. So moving on to thinking about, you know, kind of clinical colonization and action, and thinking about, you know, what role does the DSM play in all of this, right? And so a lot of folks are like, well, as long as we account for culture, we're doing an okay job, right? Like, it doesn't have to be maybe a study with known effectiveness with my community, but maybe if I can individually account for culture myself, then that can kind of make up the distance, right? So let's take a look at, how culture has been treated throughout the DSM, why we even talk about culture in the DSM, and then eventually we'll kind of get to, where we're all going with this, right? Problems with clinical colonization and taking a look at culture. Alrighty. So if we're thinking about, I feel like I don't really need to tell you all why culture matters, but I'll let you know my thoughts. So ultimately, we have to understand folks' worldview or where they're even coming from to understand how they're experiencing what we're describing as illness, right? And so using the language of the DSM, right, we have to understand folks' experiences of their illness in order to be able to diagnose it. And so we really cannot understand folks' symptoms or what brings them in without knowing, what the heck is going on, right? Or how they're even interpreting the events that are happening in their lives, right? So ultimately, culture matters. So whenever we're thinking about, just kind of this overall worldview again, like we've been talking about, there are just fundamental differences in collectivist communities and individualist communities, right? And so it's really important to even think about that before you even get to specific like racial cultures, but just thinking about overall kind of like just individualized versus collective notions, right? And those can cross racial and ethnic groups, as we know. So thinking about egocentric conceptions of self, right, is that very like individualized approach to being in the world, right? So if we think about folks raised within the United States predominantly, that kind of like pull yourself up by your bootstraps mentality, right? It's very individual, accomplishment driven and autonomy, like focusing on this individual doing well, right? The climb to the top, the Cinderella story, right? Like that one individual doing well. If we think about sociocentric conceptions of self, right, these are more collectivist cultures, specifically with Indigenous communities. So we really focus on the interdependence between groups, right? So, we just had, what was it, the 4th of July, right? And everyone's talking about independence and all those sorts of things. Like that is fundamentally the West, the United States, right? But then thinking about sociocentric or collectivist communities, that really is interdependence, right? We rely on one another because we're in community. And so thinking about this applying to clinical practice, right, we want to think about how we're experiencing or expressing these symptoms differently, because that ultimately will change how that's interpreted for diagnosis and treatment. So like, I have lots of examples, so I'm trying to think of like the best one, but really just thinking about there are not really items on the assessment instruments that we're using that account for these collectivist ways of being in community, right? So thinking about things about like grief, right? So let's say that, even for bereavement or for being, to get off of work, right? You have to like see a bereavement counselor and they have to talk to you. And so a lot of those are very inherently individual focused, like you have to be immediately related to that person to be able to qualify for bereavement leave from work. And that's fundamentally at odds with collectivist cultures, right? Because like thinking about like if we lost an elder in our community, like just because I'm not blood related to them, like and they're not in my immediate family, doesn't mean that I'm not still greatly impacted by that loss. So when thinking about trying to use this in, working with our clients and really holding space for them to tell us, what's going on and how we can, what actually brings them into our care, how we can even make space for this kind of collectivist worldview, beyond just that individualized focus, right? So overall, we know that folks need to understand that our culture permeates our lives, right? We don't just like set our culture on the shelf and then go throughout life and then come back and pick it up when it's convenient. So like I always say, like our lives don't occur in a vacuum, right? We really cannot say like, this is the part of my life that is experiencing anxiety and this is the part that is experiencing depression, right? Like that's not actually how things work in the real world, right? And so the way that the DSM is just kind of like upheld and, you know, really gone to as like the go-to portion, it's thinking about how important culture should be. It's really like a shame that it's treated so inconsistently throughout the DSM, right? So it really appears in more like introductory kind of things like, oh, you know, you should definitely account for culture, but it's actually not in the diagnostic criteria itself, or like they'll add different things like in the appendices, but in thinking about how we can actually implement it into clinical practice and really critically think about the role of culture, it's really not put forth in the DSM. So folks started looking at cultural context in revisions from going from DSM 3 to 5. So in 4, we had this sort of broader discussion of culture, and they put this kind of this sentence here that was great to say like a clinician who's unfamiliar with the nuances of an individual's cultural frame of reference may incorrectly judge as psychopathology those normal variations in behavior, belief, or experience that are particular to the individual's culture. So this is fundamentally saying that like if we don't understand where folks are coming from, like from a cultural perspective, we might diagnose those sorts of things as being a problem, right? As pathology, when they're actually pretty normal to their culture, right? It's very, you know, culturally patterned. So an example here is thinking about there was a study that came out and said that American Indian men were more likely to be diagnosed with personality disorders. And it was like 3 or 4 different personality disorders. And we were like, that doesn't make any sense. Like, I mean, you know, we all have that uncle, you know, that that one Native man that he needs to get it together. But personality disorders, like it just doesn't make sense, right? And so whenever folks began to kind of look at this, there was a question that was looking at like impulsivity. And so they were like, oh, Native men rate really high on this, like they're very impulsive, they're very sporadic, right? And whenever they like actually investigated it and asked people like, what do you interpret as this question? The question was like, would you leave an important event or leave your job or something if there was some kind of, you know, need or, you know, a family emergency or something like that? And so a lot of the Native men were like, yeah, I would absolutely go, because if I'm a person of the community, so if I am needed in the community, I will go. Like, and that's absolutely in line with our cultural protocol, right? Like it happens to me all the time, right? Like I'm like, these are like places that you work with as, you know, as a community scholar, as a, you know, community grounded person, clinician, right? You know that like whenever you are called upon, you go, right? Like it's not a question, right? Because that is you fulfilling your community obligations, right? Or just your responsibility of being a good ancestor. And so it was just so strange that they were saying, oh my gosh, Native men have personality disorders. And it's like, they're actually acting in ways that are very in alignment with their culture. They're actually like living out their cultural values. So I don't know how that's pathology, right? But it's again back to who is asking the questions, who's creating these criteria, and whose worldview is being reflected in these questions, right? So within the DSM-4, they added this kind of outline of cultural formulation, and then they added this glossary of culturally bound syndromes. And we'll talk more about those in just a second. So whenever we get to the DSM-5, there's this new enhanced, they enhanced the prior framework that they began to work on, right? So they were actually kind of had a little, hint of notion that they knew what the heck was going on in the outside world, right? They said that, disorders themselves should be defined in relation to cultural, social, and familial norms and values, right? Which was like a pretty big thing because their whole book is like counting symptoms and like problems. So for them to be like, oh yeah, I guess you could actually like think about all this other stuff in relation to it. It's like, you think? Like, so they really wanted to highlight the way that culture provides these interpretive frameworks, right? And so I think a lot of times whenever we think about just culture, it's a huge concept, right? It's kind of this just large floating cloud of culture, right? And it's like nobody really knows what that means or how to interpret that meaningfully into clinical practice, right? Like, is it language? Is it immigration status? Is it, identity? Is it, what is it, right? And like, it's different based off of who you ask, right? I don't think anybody in, any kind of racial community thinks of culture as one way, right? Or like for Native communities, we often talk about tradition and culture, right? So they're really kind of like, you don't really separate them. You don't say Native culture, we would say tradition and culture. And so thinking about kind of like, how do we even begin to put this into a formulation or a document or this diagnostic and statistical manual that can actually meaningfully help us work with folks from different cultures, right? And so we're like going up throughout time, like they're getting better at looking at culture, but it's still like we're not there, right? It's still kind of, I think it's still too abstract of a concept for folks to really kind of meaningfully grasp onto. So thinking about what we used to look at was just like culturally bound syndromes, right? And so so I love this, right? Because we're like, oh, we should like use people's perspectives and like look at, like wellness instead of, illness. And then they're like, no, let's just make the intervention, like, let's just make the diseases in their language, right? Like they're like, we don't need to think about wellness or anything that they're talking about. Let's just actually describe them tribally specific, right? So there's all of these different things that came up that are listed here. There's another one on the next slide. So just thinking about how things are described, like loss of appetite, sleeplessness, depressed behavior, crazy sickness, worry sickness, heartbreak, right? Like, and to me, these things are like, I would not I would not hear somebody describing what they're going through and think like, this is a diagnosis, like that's just not how I would go about it. So there's other things that were included in the DSM-4 TR and 5, things like ghost sickness, soul loss. So a lot of these are Indigenous as well. So thinking about folks that were crossed by the border and now are also below the border as well. So our Indigenous relatives in Central and South America as well, they're reflected in these diagnoses as well. It's a lot here. So this is the article down here if you want to look at from Thompson that came out in 2014. But even these are really not getting to what we were looking at, right? So thinking about like, oh, well, if we just had a name for what they're experiencing, then that would be fine, right? But even having the idea of culturally bound syndromes are still not encapsulating the whole issues that we've been talking about, right? There's still clinical colonization and even imposing the idea of diagnosis upon marginalized communities. But then now thinking about this, to me, a culturally bound syndrome is not still accurately accounting for culture, right? It's just another checkbox, another way to say like, oh yeah, this is this, right? Like you can count this. And so most of these have been removed as well. So recent revisions, like we've been saying, they're increasingly saying culture is important, we need to think about this, but they're also kind of like adding more diagnostic criteria that are decontextualizing these disorders, right? So it's like we're saying add more nuance, be more complex, think about culture, but then we're also simultaneously like adding more criteria and making it more individualized and nuanced and standardized, right? Not nuanced. And so the DSM overall is just kind of like, again, this huge contradiction in thinking about, you know, diagnosis or working with marginalized communities, right? So like a lot of Indigenous folks and languages, we don't have words for concepts like depression or anxiety. And so like even the idea of like culturally bound syndromes being like, oh, well, this is their version of depression. It's like, not really. Like that's still trying to like make a Western concept fit into a non-Western community. So overall, we have to have more room for nuance, right? To really kind of have this space to have this really in-depth cultural assessment in conjunction with all of these other things that folks are experiencing, right? And so how can we contextualize our diagnostic impressions to include these sociocultural and psychosocial environments, right? To really have folks bring their full selves and have that reflected in our work together. Yeah. So we've kind of been through, you know, evidence-based practice and taking that down and looking at interventions, starting to question, you know, who decides what counts as evidence and how is it evidence for our communities? Looking at how culture is treated throughout the DSM and how this kind of perpetuates this problematic, you know, Western ways of knowing again, right? Again, still counting symptoms, reflecting hierarchies, and just really kind of trying to fit our communities into this other perspective whenever that's really not where we're coming from, right? So the proposed solution, or just maybe an avenue of hope for this, and where we'll kind of wrap up our time together, is thinking about the overall idea of decolonization and kind of where can we go from here, right? Like it's a lot of information and it's a lot to kind of start to sort through and break down. So we want to make it meaningful for you and have some time to kind of process and reflect and see where that will take you on your journey. So thinking about decolonization, it's another concept that has been co-opted and turned into a buzzword, right, or hashtag. So fundamentally, decolonization is the undoing of colonization, right? Like de-escalation is undoing escalation, right? So like decolonization is undoing colonialism, right? Whereby a nation reestablishes itself, right? And so decolonization is not just for American Indian folks, right? Decolonization is for everyone because we have all been impacted by settler colonialism, right? And so ways of decolonizing include like returning to traditional ways of being, such as learning your traditional practices and languages, addressing our own internalized oppression and colonization. So Dr. Michael Yellowbird has a lot of great work on neuro-decolonization, and that kind of integrates mindfulness in with working with decolonization. And so the overall logical endpoint of decolonization is the dismantle structures, right? So some folks critique this as like, we can't like put Pandora back in the box, right? Like we can't undo these sorts of things. But decolonization is ultimately this expansive framework that kind of positions us to think about decolonial futures and what a world without X issue could look like, right? So what would a world without clinical colonization look like, right? So a lot of things that decolonization is not. Decolonization is not a buzzword, or it is a buzzword, but it shouldn't be. And so folks that are saying, you know, hashtag decolonize or decolonize your syllabus or all of those sorts of things, right? Decolonization is not just checking to see if you're citing people of color in your syllabus, right? Like, that's great and you should, but like that doesn't fundamentally change any structural problem, right? And so thinking about if you want to just have that kind of, first toe dip into decolonization, I highly recommend you read the article. It's called Decolonization is Not a Metaphor by Tuck and Yang. That's a great place to start. And then thousands of people have cited them since then. And so that's, more places to kind of, if this piques your interest and you want to go down the decolonial rabbit trail. So thinking about, while we want to do things that will improve our societies, our schools, our practice, right? That's great, but it really is not a metaphor for the things that we want to do, right? We don't want to do a disservice to folks that are doing truly decolonial work that are actually like undoing these power structures, right? So there's a lot of short-term work that people are doing that's not decolonization, but it's helpful, right? So again, like changing your syllabus, decentering knowledge, doing different things like that. Like that's really nice and lovely, but it's not decolonizing, right? So there's a fundamental difference between social justice work and decolonial work, right? So social justice perspectives kind of seek to look at, like diversity and inclusion, reforming problematic things. You'll see things like representation matters, right? Like recognition. So there was a campaign forever ago, probably not forever ago, but a couple of years ago on like indigenizing colonized spaces. And so they would have folks, in their regalia, and they would have a photographer, and they would take like really powerful images of, indigenous folks in contemporary society in front of these, various landmarks or whatever. And it's awesome. It's powerful. It's exciting. I love it. That's representation matters, right? But if we think about it, like there's no fundamental structural change that happens because I put on my regalia and stood in front of the St. Louis Arch, right? Like it's cool and I love it and it's inspiring, and we obviously still need that kind of work, but that's not decolonial work, right? Decolonial work is fundamentally anti-capitalist, anti-colonization, right? And the overall end goals here are focused on like tribal sovereignty, liberation, and abolition, right? So it fits perfectly with what we've been talking about the past few days. So the idea is like, well, what can we actually do, right? Like you spent the past hour just telling us how bad things are and how like we're not doing a good job. So what should we do? So here's the shameless academic plug for my article that you can read, or just kind of have an awareness that there are alternative treatments that exist. So I really wanted to look at, what are Indigenous folks doing for our own Native youth's mental health? And so that's what this article is about. And ultimately, we found that a lot of folks were doing things that specifically use culture as treatment, right? Or culture as prevention. And it was so beautiful to just learn about and think about and to continue to put out into the world that folks are doing decolonial work that are connecting people back to their communities and learning about tradition and culture, and still kind of, doing that prevention or intervention work that addresses mental health, right? So if you want to learn more about that, the article is there. And you can email me if you need help accessing it. And then even the research process that we used, we did an evidence mapping methodology, which was actually kind of like a pushback on the evidence-based practice process as well, to kind of say like, we don't need your randomized controlled trials because those don't really work well with Indigenous communities. And there are folks that are doing really great work that you would miss entirely if you were only focusing on these sort of like experimental designs or looking at these, evidence hierarchies. So that's my quick example of decolonial scholarship in both the research and the work that's being done by folks in the community. So ultimately, in thinking about, where will we go from here? How can we begin to, think about all of these concepts and ideas in our clinical practice going forward? And so a great place to start is to just kind of start questioning, like, who was deciding what counts as normality and what counts as pathology, right? Like, what are the things that we consider a problem, right? And why? And is it based on our own culture or, westernized versions of issues and things like that? And so looking to things that are community defined treatments using, community driven knowledge is a great way to kind of push back on these knowledge hierarchies of like Western ways of knowing as superior, right? Um, so we ultimately know that we need to better account for culture and really take into account these kind of indigenous conceptualizations of wellness, right? So we found a lot of interventions were using traditional healers and healing practices, um, even starting group sessions with an elder, just being present, um, was huge for folks, right? They just wanted to know, more about them, especially youth, right? Looking at the role of ceremony and thinking about wellness and how we can conceptualize um, ways to interpret that into our clinical practice, right? Um, and then overall, this kind of like relational worldview, right? To think about, the idea of, the seventh generations principle, right? The things that I'm doing today have been, put in place by the 7 generations that came before me. And the things that I'm doing today will impact the next 7 generations that will come after me, right? So it's my responsibility to be a good ancestor. And what am I doing today that could help me be a better ancestor for those that will come after me, right? And so a lot of folks think like this sounds such, like a lofty idea or just, pie in the sky sort of thing, but it's actually, it's pretty possible, right? Um, I've even heard of like, inpatient like substance use residential treatment programs. Like they partnered with their local tribal nation and they built a sweat lodge on grounds. So like the men couldn't leave, this inpatient substance use treatment facility, but they were still able to have community members come and lead them in ceremony so that they could have both that kind of like Western treatment, but then also their like fully immersed traditional practices as well. So they could really have like that kind of holistic well-being, right? Like what a concept. Even which, I mean, that was a huge project to undergo and partner with, the hospital board and things like that. I also heard recently about a community, I think up in Seattle, that they like passed like a smudging policy. So for folks that were in the hospital, right, you can't like obviously, have an open flame or a lighter in hospitals, but they had they worked to create a specific space or something and create a policy so that Indigenous families could use, the traditional practice of smudging, where there's like lighting tobacco or cedar, sage, or sweetgrass, and having that time of like prayer and reflection while their loved one was in the hospital, right? And so it's possible. It also sounds horrific to say smudging policy because I would never put those 2 words together in a sentence. And we could talk about that later. but yeah, there are decolonization is a world of possibility, right? And so I just encourage us all to think about, decolonial futures as an idea. So lastly, I'll just kind of leave with the overall idea of, next steps, right? Overall, we know that there has to be systemic change, right? The overall mission of our entire summit, right, talking about liberation, it's not like, let's help people cope better with these horrible things, right? It's like, no, we need liberation. We need sovereignty, right? We need a better world, right? And our folks deserve better. And so we have to dig deeper, right? We have to look at all of these interlocking issues and systems of oppression, right? And decolonization is one way of going about that, right? To get to that kind of structural issues in order to achieve systemic change, right? And so it's a call to action, and it's needed at every level, right? Our individual, neuro decolonization, addressing our own, our inner colonizer, and then to start decolonizing the systems that we're embedded in, right? And so wherever you can start, it's just an invitation that we're all on different places in our journey, but we all have a role to play in decolonizing and building a better world for our future generations. So Nia-ish, which is how you say thank you in Cheyenne. I just wanted to thank you so much for holding space for me to share with y'all today. I hope I didn't, I love decolonization, so it's hard for me to not get too, but I'm absolutely happy to answer any questions or send resources. My Twitter is Dr. BlackDeer. You can send me an email if you need access to any of my publications. And then my website that I think Dr. Richardson linked in the chat is also there as well. So, so thank you so much.
Thank you. Thank you so much, Dr. BlackDeer. I think that you were the perfect speaker to end the summit on, especially with the call to action that you shared. One of the sentiments that you mentioned, which I've said this multiple times, is we're not focused on providing coping mechanisms alone, right? That's important, that's valuable, that's a toolkit that we all need. But we really do want to create environments that foster our mental wellness versus threatening and damaging it because of the inequity that exists and that's embedded in institutions that we have to engage in every single day. So I think the way you ended it, the way you presented it as a call to action, I also do want to bring it to the attention of the participants that I did link your website to the chat box, because you mentioned the one article, but you've actually published quite a bit. So I wanted to let individuals know that they can find your writings there. But also, there was also some links in the chat box to some of the things you mentioned, as well as a book where you were talking about research through empirical eyes. I also linked that in the chat box as well, because you were really giving us like nuggets. You were giving us all these great jewels. And I was like, oh, bet we're going to make sure that folks know how to reach and access that information, because it was so good. So
Great.
Thank you so much for being here. And I look forward to staying connected and learning more about your work. Congratulations again, Doctor. That's huge. I celebrated that. Like I fangirl you too. So like I've watched your stuff on social media. So when I saw that announcement, I was like, yes, let's go. We've got work to do in academia and beyond. You know what I'm saying? So congratulations to you. And I look forward to staying connected and celebrating you in your professional path.